Hello, and I am your host, Sharon Polsky, and I want to welcome you back to the Healthy Returns podcast. Better health, better business, unlocking the potential of body composition. And today we are going to have Dr. Cynthia Preston on the show, and we are going to have a conversation about the BMI debate, separating fact from fiction. And we are going to dig into why we don't use BMI anymore as an indicator of health, and the biology of fat versus muscle, and what is BMI, and the history of BMI, and ways to test body composition other than BMI. So this is going to be a really cool show. And this one is a little bit near and dear to my heart because I am somebody who has always been over on the BMI scale because I carry so much muscle for as little as I am. And so, although I know being over heavy may not be great for my joints and things like that, and I am going to ask her about those type of questions because I do think that if you are over muscle, there are some other health considerations that you should think about. But from a general health perspective, you can be heavy and not obese, as BMI indicates. And so we are going to dig deep into that. And the other thing is, today in 2025, we have really accurate ways to test body composition other than standing on a scale. And so I think that we need to talk about those other modalities for testing body composition that distinguish between skeletal muscle mass, subcutaneous body fat, and visceral body fat, and why differentiating those things is really important. So anyway, stay tuned, and we are going to have a really great conversation with Dr. Cynthia Preston. So thank you so much for tuning in to the Healthy Returns podcast. And I am joined with Dr. Cynthia Preston. And today we are going to talk about BMI and separating some fact from some fiction. So welcome to the show, Dr. Cynthia Preston. Thanks for coming.
Thank you. It's great to be back. I always love your topics and they're always relevant. So I love to share and discuss with you.
Amazing. So Dr. Preston, tell us a little bit about your background.
All right. So I'm a naturopathic medical doctor. I've been practicing in Huntington Beach for almost 17 years now. Focuses on anti-aging regenerative medicine. We focus more on alternative therapies or natural supplements, natural products that work more synergistically with the body. So we try to minimize side effects and optimize health through a lot of our interventions. And it's really just about having more tools in our toolbox for individuals.
And that's the thing, is like BMI comes up all the time because most of our patients, I work on the functional medicine side too as a coach, and most of our patients are coming from traditional medicine. And so their doctors are talking to them about BMI, and then they come to me or they come to somebody like you,
Yep.
and they say, well, what about my BMI? And we don't even talk about it. And so that's why I wanted to have you on the show so we could have this conversation about BMI and why alternative medicine, functional medicine, longevity is starting to steer away from BMI, especially now that we have ways to measure other indicators of health, and why we are starting to see this shift away from BMI.
Yeah, so I was like kind of explain why the BMI has been so important, why we've used that for so long. And it's really more, it became very popular because it was more for public health measurements. It was a way to look at the greater good, improve certain things. You can even go back to the 1800s and you could say, hey, it started due to insurance. Insurance wanted to optimize their payments, and we could say, hey, this is a higher risk group. And then really clinically, BMI became really the easiest thing that we could do clinically in the office.
So BMI is just a scale it's a scale that says if you are X height at X age, you shouldn't weigh more than X. And it's just long scale.
It's just
but who created the scale? Is it a little bit of a arbitrary scale, or how was it created to begin with anyway? And when was it created?
Yeah, so it was created. You could go, like I said, all the way back to the 1800s with a lot of our what we call polymathematicians. I mean, super smart guys that basically said, "Hey, we could lump the population, we could understand risk factors, we could optimize health." You could say, like I said, little eugenics and their little optimizing genes. There was that kind of old school mentality, and that's also why we're starting to go away from it because we realize it's taking into account a bigger population and not the individual. And so BMI came about, used to be how you would test it, was either dunking somebody in water or using x-rays, which is the gold standard now, but it's really just taking height and weight and it's just putting you into a category. So it's not taking into account muscle mass, bone mass, water. So all of those things are really important in understanding the overall fitness and disease risk for a patient. And while we've come away from that, is there is more research, specifically with cancer risks, looking at other indicators other than BMI, but it really clinically has been used because it's easy to do in a clinician's office, right? So we don't need big machines. We don't need a water dunk tank, and we don't need an X-ray machine. So what we use in the clinic and has been around for a long time is body impedance analysis.
When was the last time the BMI was updated? Because women today versus women 20 years ago, our lifestyles are so much different. We are far more active. We lift weights now. We have physical jobs that we didn't have as homemakers in the 1940s and 1920s. So when was the last time the BMI was even updated for a modern population?
That's a great question. I don't
And
know.
you
It
don't
hasn't
have to
been.
know the answer, but it's always been something I'm curious about.
Well, I know about 10, well, almost only 15 years ago, a bunch of our medical obesity associations, the one that dictate and do a lot of research with that, they kind of came together and say, we have to find something else. And this was about 15 years ago. So we've been saying since then, this isn't the way we
Working.
should do that. And that's about when I started using the body
BIA
impede.
technology. Yeah.
Yeah,
And
other tech.
I think BIA technology is the wave of the future. It's very easy. It's inside. It's like,
Yeah,
nobody has to take their clothes off. They have
yeah.
to be hydrated, which we can control that dynamic. It gives us so many different, can give us 25, 30 different factors to judge health on. And there's no radiation. So it's one
Yeah.
of those things that and people could do it every 30 days and really monitor their progress. So I am in love with BIA.
Yeah.
I think it's the gold standard for monitoring progress that we're going to see for a very long time to come. What is your experience with BIA?
So it's funny you say that. I actually found this is what I started with. I don't know if you remember these.
I do
This is
remember
more just for
those.
BMI, and it would give percentage of body fat. And so this again, this is why I'm saying clinically this is so easy. It doesn't take up space. You don't have to
Yeah.
have fancy big machines. So I've been using a body impedance analysis for 15 years. It's a pretty big machine, but I've used it because women's health has always been my specialty. Women over 45, and it's a better indicator for muscle mass, bone mass. So we can actually look at bone mass, fat-free mass. So it's about understanding the risk factors and understanding the body type for women so they don't come in and they're frustrated or they're scared or maybe they just want overall wellness. The body impedance analysis, impedance is the key. So it's basically using an electrical current and it's measuring resistance. So different tissue has different resistance. And then there's a fancy logarithm that the smart guys put together, and it gives us different numbers. It also tells us where fat is distributed. So this
That's
is,
my favorite part about BIA is it tells me my subcutaneous from my visceral body fat. And like I have clients that are in Alaska. They carry more subcutaneous body fat than my clients that live in Florida where it's never below 70 degrees. And those are some normal parameters. So way back in the day, we could only get a total body fat percentage number. Now we can differentiate between visceral body fat and subcutaneous body fat, which to me is so important.
Right. So visceral adipose fat is what we carry around our abdomen. It's the fat in between our organs, and that is the main area that we associate now. So this is where the research has gone, is that it's what's really around our waist. It's the specific type of fat that we carry around our waist that we actually consider it its own organ now. It can do its own hormone secretions. It can ignore your brain. So it's a very independent organ that can be affected by a lot of things. This is important to know. This is usually like your apple shaped body where they're carrying that fat. And we know that's a higher risk. They can have skinny legs, but if they're carrying around that extra body
Yeah.
fat, they could I say they could because there's so many other factors that play into saying what somebody's risk is really going to be. And so it's understanding, hey, this is where you're carrying fat. Maybe your BMI is going to be lower or your muscle mass lower because you carry it differently. So it's really looking at, yeah, that visceral fat. And that's
And
where,
that visceral fat is our indicator now for heart disease, fatty liver disease, type 2 diabetes. It
right,
really is something that when we start to catch that early on, we and make those changes to visceral fat, we really can help with longevity and health outcomes for our patients.
right. And that's why I say sometimes it's almost better if your body fat percentage is higher. If it's kind of everywhere, that's fine. But if you're holding that mostly around your waist, that's when we're going to have some concerns. And maybe that's going to be just one objective measure that we can follow. And there's also not just waist circumference, but waist to hip ratio too.
Yeah.
So we talk about there's certain numbers that we want to look at. Men and women are also going to be different for all these numbers. So understanding that, usually a basic rule of thumb is your waist circumference should be half of your height. So sometimes that's just where we go off of. Again, it's not a straight rule, but that can also be easier for patients. They could just do that at home.
Yeah.
And so again, that's kind of taking off the clinical burden. So it's just a matter of understanding where that fat is displaced and where you're gonna hold it. Same thing with
And when
muscles.
we
So
talk about BMI, when we talk about fat and muscle, muscle is denser than fat. So if I
right,
were to weigh this much fat and this much muscle,
yeah,
muscle is going to weigh more than fat. And so that's why we're having this issue with BMI,
yeah,
because a lot of our population can be over muscle, shoot them up on that BMI scale, but they're not at risk for health issues.
yeah. Yeah. So I usually I give the example of a glass. You could put 1 pound of fat in one and 1 pound of muscle in the other. That fat's actually going to overspill on that same cup, whereas muscle maybe only will fill half the cup because it is denser. It takes up less space. But this is why someone can, with a BMI, say a really elite athlete, can register as obese, but they just have a lot more muscle mass versus somebody that has not as much fat, and they could register as maybe just overweight or healthy. So also, there's a lot of research with these obesity associations, research with what's called the Edmonton Obesity Scale. And that's something as a physician where there's certain categories. So again, somebody with a BMI of 36, but they have sleep apnea and they have hypertension. Okay, that doesn't sound great, right? They have what we call these comorbidities, BMI of 36, but it's maybe somebody that has a BMI of 40 and they have just borderline hypertension, maybe some back pain, but they have a higher BMI, but they're actually going to be lower risk also because they don't have these what we call these higher comorbidities. So a lot of researchers kind of pushing towards that. But again, it's harder to change a bigger, larger scale of clinicians to start going into that. But I think it's important to have these bigger scales and all these systems because then we can sit down with the patient and we can talk about this. It's when somebody goes into the doctor's office for a virus, and they get weighed and their height, and now they're getting a conversation about their BMI, and that affects their mental health. That affects a lot of things that play a role
Well, a lot of
into,
people don't go to doctors anymore because they're
well,
afraid to be put on the scale, because they're
exactly.
afraid that they're going to get shamed over it. And
Yep.
it's funny because I work with a lot of bodybuilders, and that's
Right.
like, Dr. Lee, I know Dr. Lee, we both
Yeah.
work in that whole bodybuilding arena. And we have this conversation with bodybuilders all the time. They don't want to go to the doctors because the doctors actually are like ridiculing them and shaming them for being so large. And
Yeah.
now I will say, I don't always agree that very, very high weight from muscle is also a good thing. Like, we also have seen with bodybuilders, and I mean, drug-free bodybuilders, things like that, where they have tremendous joint pain, a lot of issues from being too
Yeah.
hot, heavy from muscle. So this
Yeah.
also brings me back to why I love BIA technology so
Yeah.
much, because we can look more in depth into ratios. So we can
Yeah.
see if people are too heavy in their torso, even if it is muscle, and too light in their legs, and all of these things that we can take into consideration. So it isn't just BMI, we can take all these other factors into consideration.
Yeah, absolutely. And I think, yeah, I think it should be somewhat complicated, because if it's easier, then we jump to conclusions, like these people that are going to the doctor's office are not going. If we make it complicated, we make the doctor spend a little time, the patient spend a little time, then we can really have an honest conversation about their health. But yeah, BMI, it's almost too easy, and then yeah, then you have this fear aspect of health. And really, I think this is where the whole world is really changing and understanding, and not fat shaming or body shaming just in general, and really understanding that even even your circumference, even BIA alone, it's not a predictor. You really have to understand, are they moving? Are they just sitting on the couch? Are they what are their genetics? Where's their environment? What's going on with their hormones? There's so many other things that need to be played and need to be analyzed with these kinds of scales that are now being developed. But like a big change, it never is implemented very fast. But that's why there's people like us that are a little bit ahead of the curve, and trying to talk more about it and get patients to understand. But yeah, the BIA is just, it's really important. Men, they can understand, their muscle mass, the relation of visceral fat to their testosterone. Women, a lot of times with just even the BIA, I can maybe think that there's maybe some early osteopenia, osteoporosis. We can see changes, again, with fat-free mass. So this is basically everything that's not fat. And we have to understand too, what I like about BIA, sometimes we see even their organs, we can see their organs getting bigger. And that's actually usually a good thing. Organs are mostly smooth muscles, a different type of muscle, but we can look at that and say, hey, maybe you didn't make changes this week, but I can tell there's more growth hormone in your body. Things are getting bigger, the demands are getting bigger. So it's just a really amazing tool to get patients to kind of not focus just on fat.
Or just weight.
And
I feel like we still live in a society where people are just focusing on their weight. I
yeah,
work very heavily in GLP-1 weight loss coaching, and our doctors are still just weighing patients to
yeah,
determine whether or not the medication is working. But I've got them on a weightlifting program. And
right.
so I use BIA technology to test all of my patients, and the doctors don't even care to look at my BIA. And I'm like, they don't need more medication. They're building muscle and losing body fat. So yeah, but the scale isn't going down. And
Yeah.
so there's this massive learning curve right now just in our medical education about BMI, and I don't know how we change that.
Well, I think it's changing, and I think it's educational things that we're doing, like we're doing right now, writing about it. Just, it's patients that are going to be the best word of mouth for their friends and their family. We just want our family, our circle to be healthy. And sometimes they're not ready for it. It's not fast, but that's a good question. I mean, I'm always trying to figure that out myself. And I think health fairs, volunteering, just if you are educated and listening to these podcasts, this is something you as an individual can really change. You don't need a doctor to say, hey, there's BI. You could buy BIA home scales now that are accurate. Technology, I think, is really helping with this.
So your advice to patients, our general public, is to seek out BIA. Go to your local gym, try to find a BIA scanner. Go to your local functional health clinic, try to find a BIA scanner. And the more we normalize BIA testing for everybody, the more that the medical industry will start to adopt this as a really good, solid modality to start looking at general health of our population.
Yeah, no, that's a good point. Every gym has it now. I see there's a lot of different scales, but I see them everywhere now. Whereas just a couple of years ago, people would even go on my machine and they're like, "What is this? This is crazy. I've never seen this, never heard of it." And now they're not addicted to it, but they definitely want it. They'd rather see that machine than me because it'll give them, more of that quantifiable numbers. And I think it's beautiful. We have an aging population again, where certain screenings aren't done, and that's an easy way to understand, where they're at. And that's another population, right? Like understanding certain age groups. So usually, like if you're 65 and older, we want a little bit more fat on you. That helps with bones. We actually see fat mass can be a little bit beneficial for certain groups. Asian, African American populations, they have a little bit different risk. Their numbers should be different. Again, it's just not about lumping everyone together. And I think that's an easy place, is to just go to your gym. I think that would be great if everyone you could walk into the grocery store and have a machine.
Yeah, seek out a BIA machine, test yourself, and then walk right into your doctor's office and say, "Here you go, doctor. What do we do?" Now, on our side, we need to start teaching the doctors how to read that and analyze that and use that data. But the data's there. The data's available for everybody. The data's available for mainstream population to get to. You just gotta go and want to do it.
Yeah. And you got to be an advocate for yourself at the end of the day. And I love that. Yeah, you could take that color copy in, but it's changing. Those machines even have really good, simple readouts.
Yes, very simple.
Yep. And it's lifetime. And that's the best way to do that.
Yeah, I totally agree with you. Dr. Cynthia Preston, thank you so much for joining me for our podcast today. And we will be in touch soon. I'm really happy you came on board and had this conversation.
Oh, this is so much fun. I wish we could keep going, but we'll do it again soon.
Thank you so much. Have a great day.
All right. Thanks, Sharon.
Thank you so much for tuning in to the Healthy Returns podcast. I'm Sharon Polsky, and that was Dr. Cynthia Preston. We hope today's episode gave you valuable insights and inspiration to drive success in health, wellness, and business. If you liked today's episode, please leave us a review and follow for our next amazing episode. Every 2 weeks, we air a new episode. And for more information on BIA technology, I would love it if you would visit our website at www.evolt360.com. Until next time, stay inspired, stay informed, and let's keep working together to make the world a healthier place. Ciao for now. The eVolt podcast is for informational and educational purposes only. The content shared here represents the views and opinions of the host and guests and should not be considered medical, health, or professional advice. This podcast is not a substitute for individualized care from a qualified provider. Please consult with your provider before making decisions that may affect your health and wellness. Any statements about treatments, health protocols, or medications discussed are based on personal experience or professional expertise and may not be suitable for everyone. Always seek personalized advice from a licensed professional who understands your specific needs.